Sir, good evening, sir. Damodharan, sir.
Good evening. What
Sir,
is your topic?
sir, frailty and eclampsia, sir.
Okay.
We'll talk about frailty, sir.
Frailty.
Yes, sir, frailty. Frailty is defined as a multi-dimensional clinical syndrome characterized by decreased physiological reserve and increased vulnerability to external stressors resulting from cumulative decline in multiple physiological system. It is a distinct form of chronological aging. While aging is universal, but the frailty is a pathological state occurring in the subset of elderly individuals. Normally, it is commonly in more than 65 years. Its prevalence increases with high age. About 10 to 15 percentage of community, especially in elderly, and 40 percentage among the hospitalized surgical patients. More frequent in females and those with multiple comorbids and malnutrition. Pathophysiology. Frailty represents the state of physiological dysregulation involving multiple systems. First, the musculoskeletal system. It causes sarcopenia, which means a loss of muscle mass and strength. In neuroendocrine system, it has reduced anabolic hormones such as testosterone, DHEA, IGF-1. In cardiovascular system, there will be impaired baroreceptor reflexes and reduced cardiac output reserves. In respiratory system, there will be a decreased vital capacity, poor cough reflex, and reduced oxygen reserve. In renal system, there will be a decreased glomerular filtration rate and fluid regulation. In neurological, there will be cognitive impairment and there is a high risk of delirium. In immune system, there will be a chronic low grade inflammation, which results in minor insults. So in this pathophysiology, such as in minor insults such as infection, surgery, or anesthesia, which may lead the patients to disproportionate decompensation. The clinical features are mainly unintentional weight loss more than 5 kg per year, weakness and fatigue, slow walking speed and poor balance, decreased activity level and endurance, frequent hospital visits, and frequent history of falls. There are multiple assessment tools for this frailty. First, we'll discuss about the fried frailty phenotype. It is based upon 5 criteria. The first criteria is unintentional weight loss. Second one is exertion. Third one is weak grip strength. Fourth one is slow walking speed. Fifth one is low physical activity. In this, if we have more than 3 criteria, the patient falls into frail. If the patient has 1 or 2 criteria, it belongs to pre-frail. The second clinical scale is clinical frailty scale. It has 9 point pictorial scale. The 1 is very fit and 9 is terminally ill. It is a simple bedside tool for perioperative risk assessment. The third scale is Edmonton Frail scale. It is a multi-domain tool including cognition, mood, balance, nutrition, medication use, social support, and functional performance. The fourth one is a Frailty Index. It is based upon the proportion of health deficit present from the defined list. So, what are the perioperative significance in the patients with frailty? The frailty is an independent predictor of increased post-operative morbidity and mortality, prolonged ICU stay and hospital stay, increased incidence of delirium and post-operative cognitive dysfunction, functional decline, and under the hospital admission. So, what are the perioperative management in this patient? So, first we need to identify the patients, screen all elderly patients more than 65 years using the above scales. Optimization in these patients, especially control comorbids like diabetes, hypertension, COPD, heart failure, treat anemia, electrolyte balances, supplement the patients with high protein and or vitamin diets, encourage physiotherapy, exercises, review medication, and to minimize the polypharmacy. And we have to counsel the patients, and we have to be shared decision making, explain the perioperative risk, possibility of ICU admission, regarding the functional decline. What are the intraoperative concerns in this patient? In this old age patients, the anesthesia technique which usually preferred is regional anesthesia, and preferably because it avoids the airway manipulation, and it has a less systemic side effects. If general anesthesia is required, normally use short-acting agents, low dose of opioids. Monitoring, normally standard monitorings are used. If there is a major surgery, use invasive monitoring and cardiac output monitoring. Continuous thermo monitoring is very essential in these patients, because the old age people have more tend to shift into hypothermia, which leads to its complications. Hemodynamic management, avoid prolonged hypotension, don't use fluids, use vasopressors or inotropes as needed, avoid excessive fluids. Ventilation, avoid high pressure ventilations, use high FiO2. Drugs, decreases the sedative and opioids and muscle relaxant use because of the decreased pharmacokinetic in the old age peoples. Avoid benzodiazepines and anticholinergics, and maintain normal hormoxia and a normal sleep cycle. Post-operative management, normally in HIs, in a high dependency unit or IC observation after major surgery, early mobilization and physiotherapy and nutritional support. Multimodal analgesia, avoid opioids when possible. Monitor post-operative delirium. Use CAM score for PCOS. Early oral intake and family involvement in the care. That's all regarding the Fraility, sir.
Is there any role for tug test in this?
Sir, which test, sir?
Tug test, TUG, tug test. Have you heard of that?
Tug test.
It was asked
In
as a
delirium.
short note question in one of the theory papers two terms ago.
Sir, it's a time up and go test.
Timed up and go test. Yes, it is also called up and go test also in some books. What is there any role for that in assessing the frailty?
Yeah, yes, sir. It used to assess the functional motility, risk of falls, commonly assessed in geriatric patients and fertility evaluations, sir.
So it can be used as an objective test. Okay, apart
Okay,
from
sir.
assessing the subjective feelings, it is considered as one of the objective tests that can be included in preoperative assessment of frailty. Okay?
Okay, sir.
Right. Okay. So otherwise, all the other points that you have mentioned are quite adequate for this answer. You can continue with the second part of your question.
Okay, the second topic is about eclampsia. Definition: eclampsia is defined as a occurrence of one or more generalized tonic-clonic seizures or coma in women with pre-eclampsia, especially hypertensive proteinuria after 20 weeks of gestation, not attributed to other neurological disorders. Incidence: it occurs approximately in 0.3 to 0.5 percentage in all deliveries in developing countries. It's a major cause of maternal morbidity and mortality, responsible for complications such as cerebral hemorrhage, pulmonary edema, renal failure, and DIC. Pathophysiology: normally in pre-eclamptic patients, it is due to endothelial dysfunction and vasospasm, which leads to hypertension and reduced organ perfusion. In cerebral system, it causes vasogenic edema, it causes ischemia, and it causes increased intracranial pressure, which leads to seizures. In renal system, it causes glomerular endotheliosis, resulting in proteinuria and oliguria. In liver, it causes periportal necrosis, elevated liver enzymes, and subcapsular hematoma. In hematology, it causes thrombocytopenia and DIC, especially in HELP syndrome. Clinical features mainly of headache, visual disturbances, right upper quadrant pain, vomiting, seizures generally of generalized clonic type, uh, postictal coma, confusion, hypertension, protein edema, laboratory findings such as elevated liver enzymes, low platelets, raised uric acid levels, and creatinine. In the patients with acute generalized tonic-clonic issues, especially in eclampsia, immediate management should be airway and breathing, maintain airway, prevent aspiration, administer, give oxygen of 10 to 8 to 10 liters per minute, place the patient in left lateral position to avoid iodocardial compression, circulation, secure IV line, monitor BP, heart rate, urine output if there is a police catheterization, control hypertension with appropriate agents, control seizure with magnesium sulfate is the drug of choice in patients with tonic-clonic seizure in eclampsia. Multiple magnesium sulfate regimens are there. First one is Pritchard's regimen, in which the loading dose of 4 gram of 20% magnesium sulfate IV over 5 to 10 minutes plus 10 gram of 50% magnesium sulfate IM, 5 gram in each buttocks mixed with 1 ml of 2% lignocaine. Maintenance, 5 gram of 50% of 50% magnesium sulfate IM every 4th hourly in alternate buttocks for 24 hours after last seizure or delivery. And second regimen is Zuspan regimen. Loading this is 4 gram IV over 5 to 10 minutes. Maintenance is 1 gram per hour IV infusion continuous for 24 hours. Monitoring parameters in magnesium sulfate. Monitor respiratory rate. The respiratory rate should be more than 12 minutes. The petallar reflux should be present. Urine output should be more than 25 ml per hour. If any parameter is absent, you should immediately stop infusion. Signs of toxicity, magnesium toxicity, loss of reflexes, respiratory depression, and cardiac arrest. Antidote is 10 ml of 10% calcium gluconate IV over 10 minutes. To control hypertension in preeclampsia, the drug of choice will be labetalol 20 mg IV bolus, followed which we can use 40 to 80 mg every 10 minutes. Maximum dose is 220 mg. If we can use hydrazine 5 to 10 mg IV slowly every 20 to 30 minutes. Nifedipine 10 mg orally or sublingual. Target BP should be less than 160 bar 110 mmHg, but maintain uretroplacental perfusion. Investigations in this patient with eclampsia, we should always monitor CBC, especially platelet count and coagulation profile to rule out HELP and DIC. Renal function test, chest X-ray and echocardiography if pulmonary edema suspected, and neurological assessment. Choice of anesthesia technique. Generally, neuraxial anesthesia is preferred when feasible. Indicated when patient is conscious, cooperative, hemodynamically stable, and adequate platelet count of more than 75,000. Advantages, it avoid, sir?
No, go ahead, go ahead. I'm not interrupting.
Okay. Advantages, avoid airway manipulation, blunts hypertensive response, provides excellent postoperative analgesia. Precautions, assess volume status carefully, avoid sudden hypotension, treat with phenylephrine or ephedrine depending upon the heart rate, avoid in all coagulopathy and severe thrombocytopenia. General anesthesia, it is indicated when the patient is unconscious or in seizing patients in coagulopathy and thrombocytopenia and need for rapid delivery. Precautions, anticipate difficult airway due to airway edema, restricted mouth opening, pre-oxygenate thoroughly, rapid sequence induction with required pressure. Induction agents should be either thiopentin or propofol, muscle relaxant, succinyl choline or acronium. Attenuate pressure response with labetalol, esmolol or opioids. Avoid excessive hyperventilation. Magnesium potentiates muscle relaxant, so adjust the dose accordingly. Intraoperative management, manage adequate uteroplacental perfusion, wedge under right hip, strict fluid balance, avoid overload, risk of pulmonary edema, continuous BP and monitoring, avoid renal toxic and hepatotoxic drug. Postpartum, continue magnesium sulfate 24 hours after last seizure or delivery. Monitor urine output and reflexes. Adequate BP control. Watch for pulmonary edema, renal failure, DAC, and help. Provide ICU care or HDU care for 24 hours. Analgesia should be multimodal. Avoid NSAIDs if there is a renal impairment. Complications in maternal, there will the patients on eclampsia, there will be intracranial hemorrhage, pulmonary edema, renal failure, aspiration, and DAC. In fetal, there will be a IUGR, preterm delivery, and hypoxia. That's all, sir.
So here there are three questions for me. One is it always necessary to have preeclampsia to become eclamptic?
No, sir, it's not necessary, sir.
It is not
Even
mandatory.
even a normal
Sometimes
patient can
de novo
have a
patient can throw a fit.
fit, yes, sir.
Yeah, so that is always. So majority of the time, the question is very quickly asked in the exam papers. When they say simple eclampsia, that means patient already has experienced a seizure attack. Then only you call it as eclampsia.
Okay, sir.
Until patient is seizure free, then only that condition is called pre-eclampsia.
Okay,
What was
sir.
the older name given to this condition?
Eclampsia, sir.
No, the pre-eclampsia or eclampsia, both were grouped under what name? This is just to find out whether your logicians have taught you your eclampsia properly.
Pregnancy-induced toxemia, sir.
It was called toxemia of pregnancy. Okay, why it was called toxemia of pregnancy?
Sir, because it was thought that some toxins in the blood of the pregnant woman which causes the disease.
They thought some toxins are entering into the blood, and that is the reason why patients are either exhibiting this high BP and proteinuria, and then sometimes throw a fit also because of the toxins. That has been disproved now, so that the term itself has been removed now. So we call it what is the current terminology that is used for preeclampsia or eclamptic patients, or this group of patients who have a high BP?
Hypertensive disorders of pregnancy.
They are all called hypertensive disorders of pregnancy. Okay, and what are the classifications of hypertensive disorders of pregnancy?
4 classification is there, sir. Gestational hypertension, pre-eclampsia, eclampsia, and chronic hypertension with superimposed pre-eclampsia.
Pre-eclampsia. So, if the question is asked only as eclampsia, now your description of magnesium sulfate therapy, is it as a prophylaxis in pre-eclampsia or a treatment for eclampsia?
Treatment for eclampsia, sir.
That is not a treatment. Whatever Pitrard syndrome, regimen and other regimens, what you give, they are all prophylactic treatments that started in pre-eclamptic patients, anticipating that they may go in for an eclampsia or a fit to prevent or avoid eclampsia. Okay. So the treatment as it is for eclampsia, of course, the first line of drug is magnesium sulfate, but it is in the higher dose, straight away intravenous. Okay. So the Pitrard regimen, the Uspan regimen, all these things are all pertaining to pre-eclamptic patients who are given these drugs as a prophylaxis before they develop a convulsion. Okay. So that need not be described if the question is worded as eclampsia. That is not suitable or correct answer for the eclamptic patient. You have here the patient is already throwing a fit. So here you have
Okay.
to straight away start the drug in a higher dose intravenously to control. And what will you
Okay,
do
sir.
if the patient's seizure is not controlled with magnesium sulfate?
Sir, benzodiazepines we can start, sir.
You are asking me or telling the answers?
Sir, diazepam for 50 to 5 to 10 mg we can give, sir.
Can you give phenytoin?
Phenytoin,
Which is also
sir.
used as a IV drug for controlling seizures, isn't it? For normal epileptic, the first drug of choice is phenytoin and not magnesium sulfate, isn't it? A
Yes, sir.
known epileptic patient who is not a pregnant lady or is a male patient who is a known epileptic, what is the first drug of choice when they throw a fit?
Magnesium sulfate is the first line of drug in this patient, sir.
For male patients also, epileptic patients?
Male first line of drug will be midazolam or lorazepam we can give, sir.
So those drugs are also, are they indicated in eclampsia patients who are pregnant? Can you give these drugs?
Yes, sir, we can give, sir. Diazepam or midazolam we can give, sir.
What is the effect on the fetus?
Um,
Will there be a fetal depression? Do they
yes,
cross
sir.
the placental barrier?
Midazolam on fetus, it causes fetal respiratory.
So these are all the questions that you have to address in this question. Okay, that is why they
Okay, sir.
ask this as eclampsia. And the
Okay, sir.
third point about once a patient has thrown a fit, we must describe how the patient will behave after the fit or the seizure is controlled. It may terminate automatically by itself, or it may respond to your magnesium sulfate that you give intravenously. Okay. So, what
Okay,
will
sir.
be the status of the patient in the post-eclamptic or post-seizure phase?
There will be post-ictal state, sir. The patient will be confused or.
So, the choice of, you said regional is the first option. So, if a
Yes, sir.
patient is confused and not very oriented, then how
The
will you decide whether, pardon?
general anesthesia is preferred, sir.
No, patient is confused, but she is not totally unconscious.
Okay, sir.
So you have to talk about GCS scale. So what is the GCS below which you have to administer GA? What is the GCS or cutoff value of GCS to decide between regional and general?
Sir, less than 13 or 14, sir. Don't
13
know
is
this.
very high, good value, isn't it?
Okay, sir.
I am asking the cutoff point below which you have to go only for GA, above which you can safely give regional.
So less than 10, sir. Less than 10,
9,
we opt
9.
9, sir.
9
Okay.
out of 15 is considered as the cutoff point. So patients below 9 preferable or advisable to go only for GA. If it is
Okay.
above 9, even if the patient is slightly confused, doesn't matter, you can still go for regional. Okay. So you have to
Okay.
talk about the GCS as a guiding line for deciding the
Final or
technique of
G.
choice. Okay. So
Yes, sir.
earlier it was thought that once a patient has thrown a fit, it is not advisable to go for regional at all. Just straight away go for GA. But a lot of reports said that once you give GA, the manipulation of airway by laryngoscopy and intubation, it caused more increase in the blood pressure and caused more intracerebral hemorrhage. It was the major cause of death in the mother. Internal mortality was only due to intracerebral hemorrhage in this patient.
Okay,
That is
sir.
the reason why they prefer to go for regional in these cases. And the earlier fear, what was the earlier fear about regional in preeclampsia and eclampsia? Why they first earlier studies, if you see, they advocated straight GA only for all preeclampsia and eclampsia patients. Of late only they have switched over from GA to regional for even preeclampsia and eclampsia patients. What is the reason? Why they were initially hesitating to administer spinal or epidural for these patients, especially single shot spinal.
Um, don't know this.
The reason is the preeclampsia, one of the main criteria is hypertension. Patients used to have very high BP. So they
Okay, sir.
thought if you administer single shot spinal, they don't have enough time to compensate for the hypotension that is caused by the sympathetic blockade, and they may have a very sudden crash of blood pressure. And because
Okay.
the cerebral circulation is tuned to a higher mean arterial pressure in these patients because of the chronic hypertension they have been suffering through the antenatal period. This will cause a very severe imbalance in the cerebral blood flow, and that itself may cause or aggravate the cerebral effects, and they may go in for a cerebral function alteration. And that was the reason why they wanted to avoid regional in these cases. But later
Okay.
studies found that the drop in BP is not that severe to become, say, from 180, 110 to 80 by Korea or 60 by Korea. It doesn't happen like that. From 180, 110, it may come to 120, 80, which is still good, acceptable. And that is the reason why now we are boldly giving central neuraxial block, especially single shot spinal also. And because this point has been proved in many studies that the fall in BP is not that drastic like as expected earlier, they are advocating. But what is the modification that you have to do if you are planning for a single shot spinal in a patient who had a preeclampsia or already had a fit, and you are planning to give a spinal because the patient has now regained consciousness and the disease is more than 10 or 11. What modifications you will do in administering spinal? Will you give the same 2.5 or 3 ml that you give for a normal patient, or will you have to make some alterations in the volume and any additives to be added? Okay. So what you have to do is you don't administer the same 2.5 or 3 ml that you give for a normal healthy patient who is having a normotension. Okay. In all eclamptic patients, the advocated regimen is you give only 1.5 ml of 0.5% heavy bupivacaine and 25 micrograms of fentanyl, which is again 0.5 ml, and make a volume of 2 ml and give a single shot spinal at L3, L4 or L2, L3, whichever space you are able to get. And this will take care. Why you want to, what is the level that you want to achieve with a single shot spinal for cesarean section?
So
Dermatomal
T6
level. Huh?
up to level T6, sir.
T4 that is
T6.
recommended. Why they want what is the nerve supply of the uterus and the lower uterine segment? Hmm?
So T6 to L1, I think, sir.
Is it uterine supply is from T10 only, T10
Okay.
to L2. Okay,
Okay,
that
sir.
is for the upper uterine segment, and for the lower uterine segment, it is mostly the sacral S2 to S4. Okay, so when your nerve supply itself is coming only from thoracic 10 segments, T10, why do you want to block up to T4 or T6?
Sir, peritoneal stretch will be there.
Exactly. The fundal pressure they apply during the delivery. Have you ever watched the LSES being done?
Yeah, yes, sir.
Okay.
Normally used to give the fundal pressure.
Uh,
Normally we will give the fundal pressure. The anesthetist will give the fundal
the
pressure.
anesthetist, they will ask you to give the fundal pressure. So that time the peritoneum will be stretched. That will cause a discomfort. And that is the reason why they always advocate that you have to achieve a level of T6 to T4 or at least T6. But this discomfort can be managed by adding an additive like fentanyl, and you can reduce the volume and block only up to T10, which is the origin or the route of nerve supply coming to the fundus and the body of the uterus, right? So that is how you modify so that the drop in blood pressure will be very much limited and it will not be severe even if it happens. So the patient will be comfortable and will be able to withstand the fundal pressure, and at the same time the hemodynamic stability also will be maintained. So that is the modification that you have to do if you choose to give a spinal in these patients. And GCS scale also have to be mentioned in the answer. And post-op postpartum seizure can happen up to 72 hours. It's not enough that you just monitor the patient for 24 hours. So they can throw a fit anytime up to 72 hours, that is 3 days. And so the continuation of the magnesium sulfate prophylaxis to be done up to 72 hours in these patients. If they have thrown a fit already, as in eclampsia, you cannot abruptly stop the magnesium sulfate after delivery. Okay, so these are the points that you have to include in your answer.